Good morning, everyone. Um, I'd like to welcome you to today's webinar hosted by the Postpartum Resource Center of New York State and the Schuyler Center for Analysis and Advocacy. My name is Bridget Walsh, and I am the Senior Policy Analyst at the Schuyler Center. We will begin in just a few moments, but in the meantime, in order to get to know our audience a little better, you will see 3 poll questions appear in just a moment. Please note that all these are optional, and if you do decide to participate in any of the poll questions today, your answers are anonymous. The results of the polls will be shared during the webinar today. So we'll put up a poll and we'll leave it up for about a minute.
Hi, everyone. We're going to leave the poll up for about 30 more seconds. We have a few people coming in, so I want to give them the opportunity to answer these if they decide to. Okay, great. I'm going to end the poll and share the results so everyone can see what our audience looks like today. I'm going to leave this up for just a few more seconds. All right. Great. Thank you, guys.
Okay, my name is Bridget Walsh, and I am the Senior Policy Analyst at the Schuyler Center. And so we are excited to offer this presentation on the MomD webinar series in collaboration with the Postpartum Resource Center of New York. The Schuyler Center is a statewide, nonpartisan advocacy organization primarily focused on improving policies for those living in poverty, particularly children and families. The MomD Project, or the Moving on Maternal Depression, is part of our continuing efforts to connect and improve care and resources for pregnant and parenting women and their children. Moving on Maternal Depression was part of a national learning collaborative to advance policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally competent practices in policy and systems management. Here in New York, we expanded the focus to include maternal mental health more broadly. While the national project has wrapped up, we hope to develop a state-level learning collaborative that can share best practices and information on maternal mental health here in New York. One of the projects for the MomD initiative is this webinar series. So at this point, I'd like to introduce our research associate, Brittany Eskew. That's the voice you're hearing doing the polls. She will be available in the chat for any technical questions you may have. And so now I'm going to turn it over to Sonia Murdoch from the Postpartum Resource Center, who will introduce our speakers for today.
Thanks, Bridget. Hi, everyone. I'm Sonia Murdoch, the Executive Director and co-founder of the Postpartum Resource Center of New York. The Postpartum Resource Center of New York helps New York State moms, dads, and families get to the help they need since 1998. Our statewide toll-free helpline is available 7 days a week with additional support from Moms on Call and family telephone support. Online is our free statewide perinatal mood and anxiety disorders resource directory. We also offer education on perinatal mood and anxiety disorders through our training institute, including training on our Circle of Caring support group program and various initiatives such as Project 62, the Lisa Mary Riley Visioning Education Series, and Take Care of You. If you have any questions regarding more specific services we offer, please let me know at the end of the presentation or include it in the chat. This webinar is approved for one continuing education unit for New York State licensed social workers and New York State licensed mental health counselors and costs $15. Helping Hand Psychotherapy is recognized by the New York State Education Department's State Board for Social Work as an approved provider of continuing education for licensed social workers and by the State Board for Mental Health Practitioners as an approved provider of continuing education for licensed mental health counselors. Brittany will post the link in the chat for those who would like to take part in the CEU unit. So Brittany will be posting that link. So thank you, Brittany, for that. And before we introduce our speakers, we would like to ask 2 more poll questions. And remember that these are optional and anonymous questions. The answers to the questions will be displayed for the audience to see here. So thank you for answering them if you choose to.
Thanks, Sonia. I'll leave this poll up for about a minute just to give everyone the chance to answer if they choose to. Okay, great, everyone. I will end the poll and share the results. And I'll leave this up for about half a minute just so we can get an idea of the audience today. All right, great. Thank you, everyone.
Thank you. So we're very excited to welcome today our guest speakers. And it's my great pleasure to introduce to you Dr. Scott Hartman and Darcy Dreyer. Dr. Hartman received his medical degree from Drexel University and completed his residency in family and community medicine at Penn State Medical Center. He previously worked for the National Health Services Corps in Chicago, where he completed advanced training in women's health and HIV treatment and prevention. Dr. Hartman believes in partnering with his patients and their families to create an individualized environment of care consistent with each person's values. He views himself as an advocate for patients' needs and as their link to the wider healthcare community. He also subscribes to the idea of the Mother-Friendly Childbirth Initiative and the WHO Baby-Friendly Hospital Initiative. On a personal note, Dr. Hartman enjoys spending time with his family, travel, outdoor activities, and learning about other cultures. He is also fluent in Spanish and French. Our second guest presenter is Darcy Dreyer. She is the Director of Maternal Infant Health with March of Dimes. She began her career with March of Dimes in Iowa in 2002 as a development director and transferred to New York in 2007, leveraging an opportunity in the mission department in 2011. In her role as the Director of Maternal Infant Health, she works with community stakeholders, healthcare providers, and volunteers in 31 counties from Buffalo to Syracuse. She leads the Healthy Babies Are Worth the Wait community program in Western New York, convenes upstate New York IMPLICIT sites, co-convenes the Erie County Doula Task Force, and influences various advisory boards and coalitions to adopt March of Dimes priorities and strategies to fight for improved health for all moms and babies. So a warm welcome to Dr. Hartman and Darcy. So Darcy, at this time, if you'd like to begin sharing the slides.
Good morning. Can you hear me? Thumbs up, and you can see my screen.
Sounds good. Looks good.
We're good to go. All right. Well, thank you for joining us this morning. It's a chilly Friday out there, but at least it's Friday. Today, I'm going to talk to you a little bit about the March of Dimes and our mission and goals, how New York has developed a common agenda, and how the implicit expansion project that's within that agenda. Dr. Hartman is going to introduce you to the interconception care model and the network, and provide an overview of the work that they do. And then we'll give you some resources for follow-up and wrap up with questions. March of Dimes leads the fight for the health of all moms and babies. We work to prevent and reduce premature birth, infant mortality, and maternal mortality. We're in the midst of an urgent health crisis for moms and babies, with maternal death rates and premature birth rates on the rise. The United States has one of the worst rates in the developed world, ranking 131st out of 184 developed nations, which is far too low. 1 in 7 women are treated for depression in the year before or after pregnancy, and women of color are 50% more likely to give birth prematurely. Our goals are simple, but pretty complex. We work to end preventable maternal risk and death, preventable preterm birth and infant death, and we want to end the health equity gap. And we won't stop fighting. Every day we're advocating for policies. This year at the top of our list is Medicaid expansion for 12 months postpartum. We empower families with tools. We have a breadth and depth of consumer education tools, as well as supportive pregnancy care programming. We're pioneering research, identifying markers in the maternal microbiome that will help us predict premature birth. We are supporting radical improvements in healthcare. So when babies are born too soon, we're pioneering technologies that will help them thrive and survive. And we work to unite communities together. In 2018, what was then the Prematurity Collaborative brought together over 550 partners from across the country to develop a common agenda and identify root causes of premature birth. Over the course of about 24 months, they used surveys and Zooms to solicit every potential solution that would improve health outcomes for moms and babies, and came up with 5 overarching strategies to dismantle racism and address unequal treatment, increase access to high quality healthcare, promote environmental justice, disrupt lifelong economic insecurity, and to build safe and connected communities. This is using a results-based accountability framework with our results statement of all people are healthy before, during, and after pregnancy, and if they give birth, they have healthy birth outcomes. In Western New York, through our Healthy Babies Are Worth the Wait community program and in partnership with United Way, in 2017, we conducted a SWOT analysis with community partners and identified our local priorities of social supports, family planning, and transportation. The social supports and family planning groups combined when we selected IMPLICIT as a strategy because it screens for contraception and postpartum depression, and began working to implement and expand the implicit interconception care model. And with that, I will hand it over to Dr. Hartman.
Thank you so much, Darcy. And first of all, I'd like to wish everyone a warm and happy Lunar New Year, or first day of Lunar New Year. So, and second of all, thank you to all of you for the fantastic work you're doing. I think we have partnered with some of your initiatives, not speaking just March of Dimes, but the center, and really appreciate all the great work you do for families. So the IMPLICIT network was began forming in the early 2000s as a maternal child health collaborative. It's primarily family physicians, family medicine educators. And it really kind of changed pretty quickly as they were studying models to help improve maternal child health, and really emphasized preconception and interconception care, and decided this was going to be our primary focus. And I'll speak more specifically about what I mean by that. But this network did some initial study and found this research on maternal depression and screening the concept that very few birthing persons attend postpartum visits at the traditional 6-week mark, less than 50%. And a lot of women or birthing persons don't access primary care postpartum. And so there have to be innovative models to make that happen. And really using the concept that pre and interconception care could really impact birth outcomes. It could be the key to improving birth or perinatal outcomes. So the network, after doing extensive study and a baseline survey where they really found that birthing people are very happy to talk about their own health at well child visits, developed this model that they then implemented and studied. And so we can go to the next slide. And so they call this the implicit interconception care model. Implicit is a long acronym that's hard to remember, but basically the ICC model. So we chose 4 specific components that are on the far right of this screen, which is multivitamins and folic acid, smoking, contraception or birth spacing, and maternal depression. And why did we pick these areas? So these are not the only areas that are important in the postpartum period or the well child period, the well child's first couple of years of life. But these are areas where we have really good data that intervention matters, that screening and intervention matter, and they're practical. So screening for maternal hypertension may not be as practical in the setting we're talking about. So the implicit interconception model is to screen during well child visits, a time when uptake for care is very, very high, at least in the United States, that patients from all kinds of backgrounds pretty consistently access well child visits. And this is an ideal time to focus on parental health. The big question that we get is, why aren't you doing this for dads or partners or spouses? Why are you focused on maternal or the health of the birthing person? And I can certainly address that in more detail, but to answer it simply, it's really the streamlining of the process. So smoking and depression would be good questions for anyone who brings the kid to their well child visit, but the birth spacing and the depression and the birth spacing and the folic acid piece are really for the mom or birthing person. And that's how we can impact perinatal outcomes when you add those 2 into the mix. So what this workflow, this is kind of a sample workflow on this slide for providing interconception care and the model that the network promotes, which is every well child visit doing a simple quick screen of maternal health. And so there are sample questionnaires which are not on this slide, but basically you ask some really key questions about depression, past or current smoking, is the person on multivitamins with folic acid, and are they utilizing any kind of contraception? And those are broken down into some specific areas, like what kind of contraception. It does include things like using breastfeeding as contraception or fertility awareness, things like that. So we can get pretty specific with that data. Next slide. And then, so this model of care, it was really initially implemented in family medicine sites where often the mom and baby are both patients, not always, or the mom and infant, and that may not always be the case. And then it's since been expanded to a lot of pediatric sites where the clinicians are pediatricians. The screens can be done at the visits by a nurse or another staff member, but they're always expected to be reviewed by a clinician, like a pediatrician or family physician or nurse practitioner, knowing that a positive screen may require a medical intervention. And then the kinds of interventions can really vary a lot, anywhere from just asking about depression and connecting to depression care, asking about smoking, prescribing nicotine patches, or referring out. And then where it gets a little trickier is if the clinician is a pediatrician, they're probably not going to prescribe contraception, but we build linkages to care. So a lot of the sites that are doing this have mechanisms where the pediatrician refers quickly to a women's health provider for contraception, or maybe for depression care as well, things like that. So there's really a range or a spectrum of interventions. Next slide. And I think I will skip this one, except I just wanted to mention, the reason I put this slide in here is to remind me to say that Implicit was really started as a family medicine network, but it really has expanded to include, really recognize the interprofessionalness of this work and of perinatal health, and that it's really not just family physicians doing this work. And in any given health center, it's really nurses, social work staff, front desk staff. Like in my office, the front desk staff are a key part of it because they get the questionnaire to the parents. So if they don't, people forget to do the work. So it's really interprofessional. Next slide. And then this slide is a few months old, so it's actually a little bigger, but there are 30 official network sites. I think it's at 31 or 32 now, and it keeps kind of growing every year. These are sites that are officially members of the IMPLICIT network. And we break it down by sites that are sharing data or not sharing data. And I want to say a little bit more about that, just because we can, you can certainly use this model of interconception care anywhere, but we encourage data sharing. We have these processes for de-identified data sharing with this large national network. And the value of that is that when sites share their data, they get outcomes back. And so the network has, when sites feed in de-identified data, then the network processes and analyzes, compares to other sites and sends them back, like how well are you doing with your screening rates? How high are your depression rates, but also what are your rates of interventions? And so it's a continuous quality improvement process. So it's not truly a research network, it's a CQI, or continuous quality improvement. And then when people can look at their data and see how they're doing, they can improve, right? So that's the whole goal, is that we get better and better and ultimately improve health. Next slide. So the network has a lot of data. If you think that you're doing this at every well child visit and you've got even 20 sites sharing data, that's a lot of data. So as of fall 2020, there were 29,000 dyads in the database, 107,000 visits, and then 78,000 visits where the full ICC screen was completed, as opposed to maybe just one component of that. Next slide. And I'm sorry that this slide's a little busy and maybe hard to see well, but just some takeaways from this slide. There's a value in being quality improvement and not research, in that this is real data. This is not just in a sterile lab or a controlled environment. This is like what happens in real life. So that means that our data is mixed and heterogeneous, and sometimes it's like really clean, sometimes it's not, but it's real life. So if you're able to see the very far right of this slide where it talks about intervention numbers and percent. So this was comparing University of Rochester to the network as a whole. And for example, the kind of data, when we share data that we get back from the network, is that our intervention rate for smoking in Rochester is about 68%, but 80% in the network. So we didn't do as well. And we learned that we should do better with screening for smoking and intervening for smoking. And then another example at the far bottom, the multivitamins with folic acid, so that the network's rate was 62% and Rochester was 42%. So a really good example of how we use this is that with smoking and family planning or birth spacing at some of our sites, we were able to design some PDSA, Plan, Do, Study, Act cycles to improve these rates and get better. And we specifically, with family planning, we did education for our staff, how to talk to patients about birth spacing, how to talk about LARC, or long-acting reversible contraception, as one of the most effective, but not the only, methods of promoting birth spacing. Next slide. And then, so we have published multiple research studies and presented at conferences and things like that. The trick is that you do have to really clean the data, and you have to throw out a lot of data when it's QI and not research. So you have to be really careful about what you present. But some of the real positives that we're seeing from interconception care is that we're able to show, this is late 2020 data, but looking at, well child, basically going from zero, the newborn visit, to 2 years old, we're able to show that across sites there was a 20% decrease in smoking over the course of that time period for all patients, all data that was reported in aggregate, and then 43% increase in contraception and 35% in multivitamins. And I'm sorry that the depression number is not here. I think the contraception one's particularly interesting because this is kind of the opposite of what you see in published literature on contraception and birth spacing, is that there's an initial uptake at 6 weeks and then it drops dramatically in the 2 years postpartum, whereas in our network data, there is an increase and then there's a slight decrease by 2 years, but we don't see that dramatic drop in contraception. So I think there's something really powerful there going on that'll probably be very useful to study in more detail, that this kind of intervention really works, and doing this intervention at well-child visits really works. And the contraception to me is very exciting, but I think there are other areas where we can show that this is an important and useful process. Next slide. And then I'll just say really briefly that the ICC is kind of our biggest initiative, but we're transitioning into this other thing called the Fourth Trimester Project. So ACOG and the American Congress of OBGYN and also the American Academy of Family Physicians are promoting this concept of the fourth trimester, which is sort of postpartum care and beyond, and really looking at this as a whole different place to improve birth outcomes and especially improve maternal mortality, and really infusing the concerns for racial equity in there, and listening to women, listening to birthing people in the fourth trimester and what they're saying, and really valuing what they say, and when they have symptoms, addressing those symptoms postpartum. So example, things like high blood pressure and depression and postpartum bleeding. Next slide. So the fourth trimester model, this is kind of generally like identifying risk factors in the third trimester, doing an early visit, and then an interprofessional team for fourth trimester care. And next slide. And so the Implicit Network is piloting this model right now, actually over these next 6 months, whereas some of our sites are utilizing this. We developed kind of like with ICC, like this is a model that we're going to pilot and then study it and improve it. So a third trimester risk screen, and then a hospital discharge assessment, which is something people usually already do, but then also a 2-week or actually a 1 to 3 week early new parent visit, which is not traditional. And that's really the key difference here. And making sure we have a mechanism like in Rochester and some of the other pilot sites where we will really use that third trimester screen to build on it in those 2 weeks postpartum, and then still do the later traditional postpartum visit. But we're really going to look at some of the standard things like breastfeeding and depression, but also things like how are we assessing and treating hypertension and hypertensive disorders of pregnancy, some things that are really tied to maternal mortality. Next slide. And then I just want to give a shout out to the March of Dimes Interconception Care Toolkit, which can be utilized by sites that are not part of the Implicit Network, and really want to promote this because this is an excellent intro to interconception care, but also has like, how do you do this work? And is much more detailed than what I just shared. So I would encourage everyone to go on to the, look at this on March of Dimes website. And I think you'll find a lot of great information about ICC. And Darcy, I think I'll turn it back over to you for this slide.
Yep, not only the toolkit can be found on our website, but also a ton of other great information. This is a screenshot for more directed towards consumers or moms and families. We also have a research and professionals page, and if you want to get involved in our advocacy network. So I would encourage you to go to marchofdimes.org and take a look at the resources that are there for you. We launched or implemented Implicit in New York in 2015, I think was the first site at Highland Family Medicine, and that was my introduction to the model. Since then, it's expanded in Rochester to 2 additional sites, so we have 3, one of which is a pediatric site. We, in 2018, as part of the common agenda and the work that I'm doing in collaboration with United Way, we launched with Neighborhood Health Center, and there are 4 locations, and they have adopted it as a standard of care. In 2020, we expanded to 3 additional sites, 2 in Niagara Falls and 1 in Syracuse. And then we also have sites downstate in Binghamton and I believe the Bronx. And Scott had showed you that picture of the whole region. So really trying to just expand utilization of this innovative interconception care model. And I think I'm going to end there and ask if we have any questions and pass it back to Brittany, I think, to moderate that.
Hi, yes, thank you. So if anyone has any questions, feel free to unmute your mic or turn on your camera if you'd like. And I'm also available in the chat. If you'd like to put your questions in the chat, I can get them to the speakers.
Maybe I'll take the liberty while people are thinking of questions to say that March of Dimes has been a really consistent and really the most powerful partner in the ICC work. And I know that pre and interconception care have always been something they've championed, but you know, we've had definitely other partners, but March of Dimes has been really the most consistent, and so really appreciate that. I think it's been an excellent collaboration and an example of how we all need to work together to improve birth equity.
Too, and a big thank you to Darcy and Dr. Hartman for this wonderful presentation. And thank you very much for the important work that you're doing to really strengthen the safety net for these moms and their families. So thank you. And as we continue on with the question and answer period here, we encourage you to participants to include your questions in the chat, or in a minute, we invite you to open up your cameras, that if you feel comfortable to be on screen to ask questions. And right now, so before fully moving into our Q&A session, we want to ask one last question regarding the material of this webinar series. And we want to use this webinar series as a way to bring together professionals in the field of perinatal mood and anxiety disorders and grow this network. So if there are some topics that any of our participants would like to see in this webinar series, please add them in the chat now or before logging off at the end. So again, we would like to officially open up our Q&A session at this time. So please feel free to, turn on your cameras if you feel comfortable, or unmute yourselves. I have a question to start here then. With the sites, is there still a sign-up period right now? Are you still looking for additional practices to participate in the program here in New York State?
Yeah, there's no, it's open-ended, so there are always new sites joining, and that's again the value of not being research. Even though we produce research, it's really that we're a quality improvement, so that we always, and ideally, I think Darcy and I think that like this is one of the most useful ways to do interconception care, and so we would love to partner with sites that want to jump on board and either join the network or just learn more, or develop processes for interconception care.
And I'll just add that March of Dimes' role in the past has sometimes been as a funder of the project, to get the implementation up and running. In the first year of implementation, you can often need a champion, somebody to really spearhead and move this work forward. But it is what I love about this model is that it's built to be sustainable. So once these processes are in place, hopefully you have it added into your electronic health record, then the screenings just become part of the visit. And so there isn't really a need for additional funding for sustainability. And ultimately that's the goal we all have, is to not be chasing grant funding. So part of my work in Western New York has been kind of in phases to launch new sites, and if they need funding, to find it and secure it. And we're right in the middle of our most recent go of that. But no, there's no, it's an open door. So if sites are interested, then they can connect with Scott or I, and we can hand them off and introduce them to the leadership of the network.
Great. Is there a particular criteria?
I'll let you answer that, Dr. Hartman. I don't believe so, but your site may be set up better to implement a model like this, but I've seen it in a variety of settings.
Yeah, any site that's doing well child visits really is, and I would say that fourth trimester model is separate. That's a bigger question. But in terms of the interconception model, really any site's doing well child visits. And we do, this one program in Niagara Falls is piloting doing this with community health workers. It's still technically a pediatrics health center, but they are using it in a different way. So I think we're open to all kinds of dialogue. It's as opposed to being restrictive, we'd rather have people talk about how to innovate.
Would you be able to elaborate a bit on the community health worker role in that implicit program project?
I'll take that one. We have it's actually a MTCH program through the Department of Health, and they are housed under a hospital umbrella, and their community health workers go and meet with mom and screen mom after labor and delivery, so while she's still in the hospital. And they help her schedule her first postpartum visit and her first well child visit. And an interesting thing that's come of that is they have an 85% appointment rate for keeping that postpartum visit, which is much higher than it typically is for them. The challenge is that they're not always able to follow mom and screen throughout that 0 to 2 range for those well child visits. And particularly right now during COVID, one of the pediatric practices is not allowing multiple visitors in with mom during the well child visit. So when they're able to, they're either screening over the phone or they're meeting her in the parking lot. So there are some challenges and there are some benefits.
Well, thanks for bringing that up. I think that's very interesting. Is it being piloted right now?
We have one site that's using it that way. Yeah.
I think an interesting collaborative
Yes.
idea. Thank you.
There's a question in the chat that I think we should try to answer.
Yes, thank you, Dr. Hartman. I was just going to mention, can you comment on the intervention period being defined as 24 months versus 12 or 18 months?
Yeah, I think that's a really good question. The network leadership and kind of the people that started this initially debated this, what's the ideal model? And about a year ago, they looked at this again and looked at a whole bunch of data to try to decide, like, do we really need to do this at the 2-year well child visit? And what they concluded is that at least for sites that really want to be like formal members and share data with the network, that we did want to include this through 2 years. Because when you do this at every well child visit, it gives you a lot of data points to compare back on. And the thought is that the more intervention, the better than less. And, but one thing that we do find in traditional depression screening, like American Academy of Pediatrics recommends depression screening of any parent during well child visits, but what we often see is that those screens don't happen past a year, and a lot of times they're missed at the 15 or 18 month mark. And we found in the network that in some places it seemed like the maternal depression scores were actually going up in that second year. At least some sites. We can't really say that's true across the board, but when we noticed that at some sites, we thought, well, then we're missing an important intervention. If we stop doing it at like 15 months or 18 months, we might find parents that actually have really high depression scores at that 2-year mark that could really benefit from some linkage to other kinds of care. So that was the rationale, and similar with contraception, actually.
Great, thank you.
Any other questions at this time? Dr. Hartman and Darcy, is there anything else that you would further like to add?
No, I just say thank you for joining us this morning. I see lots of friendly photos and names of partners that I know and colleagues that I work with. So thank you for coming together with us on Friday morning. And I know it's pretty chilly out there, so I hope you all stay warm this weekend.
I did see there was a comment from Ohio that there's some work to expand this work in Ohio, and we really appreciate that. And you know, a lot of the formal implicit sites are in the Northeast, and a few of them are in the South now. But there's a lot more interest as we go into the Midwest, and a Seattle site that's thinking about this. So, and acknowledging that this model is being used to some extent in various places throughout the nation, but our intent in formalizing it is to really that then we can look at data and improve data and find out sort of what's the best, right, how we can really, not everything in medical care has to be formalized, but sometimes it helps if you have really clear guidelines, like, you know, this is a highly effective evidence-based way to do something so that we can give our patients optimal care.
How does the site sign up?
So there, a lot of sites will just email Darcy and ask, how do I do this? Or go on the March of Dimes website. Others will Google implicit network and send an inquiry through them. And then they talk to the network coordinator, who also talks to them about initially how to process. Usually the implicit network coordinator will do a phone call or a web meeting with people and talk about their level of interest and exploration.
I do have another question. How long does it take to implement getting up to speed with the program in a practice?
I think it really varies from a year to sometimes a couple years, especially to do the data sharing piece, because it requires work with the electronic health record and things like that. Just implementing the model of care might only take a few months, but I think to do it in detail and to try to do it with every single patient, that's where 1 to 2 years is probably more realistic.
I see that we have a hand raised from Gabriel Lira. If you'd like to unmute yourself and ask your question.
Yes. Hi, everyone. I am calling in on behalf of a nonprofit organization called the Blue Phase. We inspire and educate postpartum individuals to live a healthier lifestyle. And we noticed, obviously, within the past year that many families have been experiencing joblessness, homelessness, and even facing starvation. And we are very interested in partnering with organizations that will directly support these families. And my question actually is, does the March of Dimes have some kind of program or network that is doing something like this? And if they do, how can I connect with them?
I guess I'm not sure I understand the question. We don't go ahead. Yeah, if you can explain.
So I guess what I'm asking is, are there any programs or if there's any organizations on the call that have been working on programs to directly impact these families who are suffering, I guess now more than they were before because of COVID? You know, people have lost their jobs, facing homelessness. I mean, postpartum is one issue, and on top of that, we're also facing, you know, a pandemic, and these people need disaster relief. Are there any programs or organizations on this call that are doing something similar to that?
So for March of Dimes, we quickly developed many digital resources for families so that women who are pregnant during the pandemic can have access to education and support. We redeveloped our birth plan to include COVID-specific questions for them and their provider. our NICU Family Support Project. When coordinators weren't able to be in hospitals, we donated iPads so that parents could better communicate and see their babies. And then on a larger scale, we work with our partners to help increase and improve that safety net function. And I think probably almost every organization on this call has pivoted. I don't want to use that word anymore. I think it was a 2020 word, so let's leave it behind. But
Okay.
but quickly started to work to provide and connect families to resources. So in Western New York, through the coalition that I work with on United Way, we're actually doing some process mapping to really identify what supports and resources we have in place for families preconception, pregnancy, labor and delivery, and postpartum, and are looking to identify those gaps. And then find those partners. And I don't know if anybody else on the Zoom wants to comment on that, but I know many of you are providing really great supports for families during COVID.
I would actually, that leads me into my next question, which is, in your professional opinion, what is a direct way that we can fill in that gap as a nonprofit? I mean, we have access to financial resources that we can leverage to directly help families that need their bills paid, or if they have issues with financial support. So is there any other direct way that we can help them?
March of Dimes doesn't provide direct service other than through our NICU Family Support Project. And so
Okay.
but I'm going to look at Daynell. She's right in the middle of my screen. She's the director of Nurse Family Partnership in Buffalo. So if she were visiting a family that had a direct need, are you wanting to provide some contact information so that the organizations that are participating could reach out in the instance that, so maybe
I would love that.
Maybe put your contact information in the chat, and if folks are working with families that need food or housing or rent assistance, then they could reach out to you.
Thank you so much.
Thank you, Darcy, for helping and answering Gabriel's question. And Gabriel, being from the Postpartum Resource Center of New York, I'll definitely, I look forward to following up with you after this webinar.
Thank you so much. I appreciate that.
Thanks for being with us today. So if there are not any more questions at all, I'd like to say thank you again to our guest speakers. And it's been a great pleasure hosting you here today. And we really appreciate you sharing about the IMPLICIT program. And thank you very much for all of your efforts. And to each of you joining us today, the Schuyler Center and the Postpartum Resource Center of New York, we invite you to continue on with us with the Moving on Maternal Depression webinar series for future presentations. So again, we thank you, and we hope everyone has a great day.